So, hello. Today we will be discussing about vasculitis. To be precise, we would be discussing about large vessel vasculitis in particularly. Okay. So, large vessel vasculitis में there are two types of vasculitis, right? So, in this we would be discussing about giant cell arteritis, right? One second, I adjusted. So in vasculitis, you have two types of vasculitis. एक तो giant cell arteritis, then Takayusu arteritis, right? So giant cell arteritis. What is giant cell arteritis? Firstly, we will discuss about another names of giant cell arteritis. It is also known as, firstly, to temporal arteritis, then granulomatous arteritis, then arteritis cranialis, then arteritis of the aged, and Horton's disease. So these are the names given to giant cell arteritis, which is temporal arteritis, granulomatous arteritis, arteritis of the aged, and Horton's disease, right? So what is giant cell arteritis? It is basically an inflammatory vasculopathy. Inflammatory vasculopathy. So what will happen, as the name suggests, there would be inflammation and it would affect the vessels, right? So which vessels would it affect? It manifests almost exclusively in medium to large arteries. Okay, exclusively it manifests in medium to large arteries. So inflammation, so what all it involves? It involves, firstly though, it involves extracranial branches of the carotid artery, then your aorta and aortic arch branches, like so. Here you get your extracranial branches of carotid artery, also your aorta and aortic arch branches. Okay, then also in aorta and aortic arch branches, it involves particularly superficial temporal artery. And another thing you have to keep in mind is giant cell arteritis is often associated with polymyalgia rheumatica. Yes. So this is what we saw till now. Giant cell arteritis. The other names are temporal arteritis, granulomatous arteritis, arteritis cranialis, arteritis of the aged, and Horton's disease. It is basically an inflammatory vasculopathy which involves medium to large arteries exclusively. It also involves extracranial branches of the carotid artery along with aorta, aortic arch branches, particularly superficial temporal artery, and it is associated with polymyalgia rheumatica. Okay. Then we would see epidemiology. So epidemiology में, as you know, the name is called as arteritis cranialis or arteritis of the aged and aging people. So it will involve the people which are more than 50 years, right? More than 50 years maybe what it will involve 0.5 to 27 per 1 lakh cases. Then females are affected more than males. How much? Females are affected 2 to 3 times more than males. Okay, and also increased risk is associated with smoking. So smoking will increase the risk of giant cell arteritis. In female, it particularly increase risk by 6 times. Okay, females में giant cell arteritis की risk 6 times बढ़ जाती है if they are smokers. This is your epidemiology. Now let's move on to etiology. Etiology में a familial aggregation is noted. Familial aggregation, especially with HLA-DR4 haplotype. Okay, So there is familial aggregation noted. Also there is genetic predisposition, and it is associated with TLR4, toll-like receptor 4 gene polymorphism. So these are some of the things which you have to just remember. Okay, so that it has familial aggregation, HLA-DR4 haplotype, genetic predisposition is noted, which is associated with TLR4 gene polymorphism. Now etiology में no conclusive causative factor is identified in giant cell arteritis. So no conclusive causative factor is noted. Now there are certain suggested triggers for giant cell arteritis. There are certain infections which are suggested triggers of giant cell arteritis. Now which are the infection? Your viral infection like Mycoplasma pneumoniae, then Chlamydia pneumoniae, then your PPP, it is parvovirus B19, para-influenza, and varicella zoster virus. Okay, so these are all PPP. Pneumonia, there are two pneumonias, Mycoplasma pneumoniae, Chlamydia pneumoniae. I don't know why the words are floating here, but I'll figure it out and during next time. So Mycoplasma pneumoniae, Chlamydia pneumoniae, parvovirus B19, para-influenza, and varicella zoster virus. These are certain suggested triggers, right? So firstly, then we will move on to pathogenesis. So what is this? We initially discussed that giant cell arteritis is an inflammatory vasculopathy. So obviously there would be inflammation in vessels. This is the gist. So you have to remember that if this is a vessel, you have. Okay, so this is a blood vessel. Okay, so this is a blood vessel in which you have adventitia, outer layer, then you have media, and then you have your intima. Adventitia is the immunological. Now adventitia is the immunological center. Adventitia is the immunological center, while as media and intima, they are your histological center. Okay. This you have to remember. Adventitia is your immunological center, while media and intima is your histopathological center. Now what will happen? So there are two proposed mechanisms. So one proposed mechanism is there will be cell-mediated immunity. So what will firstly, so there will be endothelial injury. So due to this endothelial injury, the cells it will develop an abnormal response. Then there is your cell-mediated immunity. So the cell-mediated immunity का development होगा due to abnormal response to endothelial injury. So one mechanism is this, and another mechanism is, as you know, the superficial temporal artery, which is chronically exposed to sun. So what will happen? There would be actinic damage to temporal artery, right? So actinic damage to temporal artery. This would happen due to chronic sun exposure. So these are the two proposed mechanisms which are suggested. Okay. So firstly you would so now let's move on to the actual pathogenesis. Now firstly what will happen, that there would be an unknown antigen. Now what will this unknown antigen do? It will lead to activation of the dendritic cells in the adventitia of the artery. So adventitia, as we discussed, that adventitia is the immunological center of giant cell arteritis, and media and intima are the histopathological centers. Now there would be activation of dendritic cells. Dendritic cells are your immune responsible for immune tolerance. Dendritic cells which would happen in the adventitia of the arteries. Okay. So now what would happen this dendritic cell? What would it lead to? It will lead to chemokine production. Now chemokine production would happen, so there would be recruitment of certain cells, certain T cells, so CD4 plus TH cells, they will get recruited. Now after CD4 plus TH cells recruitment, they will get activated. There would be activation of CD4 plus TH cells and they would be later polarized. Now what these TH cells will polarize into? One so TH1 and then another is your TH17. Okay, so they would polarize into TH1 and TH17. Now this TH17 will give you interleukin 17. This TH1 will give you interferon gamma. Okay, so you are getting interleukin 17, interferon gamma. Now this interferon gamma, what will it do? It would lead to recruitment of more TH1 cells. So there would be a feedback here. So it will lead to recruitment of more TH1 cells. Then along with it CD8 plus TH1 cells. CD8 plus T cells, sorry. CD8 plus T cells. Okay, so this your inflammatory process is happening in the adventitia in the vessels. Now along with it you have your monocytes. Monocytes will get converted into macrophages and giant cells. Yes, so monocytes would get converted into macrophages and giant cells. Now these macrophages and giant cells, what will they do? They will secrete certain growth factors, certain interleukins and certain proteolytic enzymes. Now growth factors, then interleukins and proteolytic enzymes. These are secreted by macrophages and giant cells. Now due to these growth factors, interleukins and proteolytic enzymes, what will they do? They would cause narrowing of the vessel wall. Okay, due to narrowing, or they could cause obstruction of vessel wall. So this is your pathogenesis. Now what is happening? This all inflammation, whatever is happening, the vessel, it is in a patchy manner. This all is happening in a patchy manner, but sometimes large segments of arteries can also be involved. So let's revise the pathogenesis. What did we see in pathogenesis? You have inflammatory vasculopathy. So basically inflammation would happen in the vessels. So as we discussed, adventitia is the immunological center and media and intima are the histological center. Now what would happen? There would be endothelial injury. Due to endothelial injury, there would be abnormal response and there would be cell-mediated immunity in response to endothelial injury. This is one mechanism. Another is there could be actinic damage to temporal artery due to chronic sun exposure. Now, there would be unknown antigen. Due to the unknown antigen, there would be activation of dendritic cells in the adventitia. These dendritic cells will lead to chemokine production. Due to chemokine production, your CD4 plus 2 helper cells would be recruited, which would there would be activation of CD4 plus T helper cells, which would later polarize into TH1 and TH17 cells. Now, your TH17 cells will give you interleukin 17. Your TH1 cells would give you interferon gamma. Now, these interferon gamma, it will further lead to recruitment of TH1 cells and CD8 plus T cells. Then there are your monocytes. Monocytes are getting converted into macrophages and giant cells. These cells would release your growth factors, interleukins and proteolytic enzymes, which will lead to narrowing and obstruction of vessel wall, which is occurring in a segmental and patchy manner. This was your pathogenesis. Now due to this, now let's move on to clinical features. Now clinical features of giant cell arteritis, you have to remember a very important criteria, which is ACR criteria in 1990. So what is ACR? ACR is American College of Rheumatology. Right? So ACR is your American College of Rheumatology. So this is a very important criteria. Now there are total 5 criteria. So you need more than equal to 3 for the diagnosis of giant cell arteritis. So what is first? So you have to remember like this, that initially there would be history, then there would be examination, then there would be investigation. Okay, so first, so patient would come into your OPD. So what you will notice the age of the patient is elderly. So first criteria is age at disease onset, which we have already discussed, that this is what is this is arteritis of the aged. As we discussed in epidemiology also, you know that it is common more than 50 years. So age at disease onset is more than 50 years. Now after patient came to your OPD, he would complain that he is getting headache, है ना, डॉक्टर साहब मुझे बहुत ज़्यादा सर दर्द हो रहा है. So second criteria is new onset headache. Okay, new onset headache or new type of localized pain in the head. Yes, now this is the second criteria. Now what you will do after headache, वो अपना सर पकड़ेगा, right? So और यू कैन ऑल्सो, आप भी उसका सर पकड़ के देख सकते हो कोई आर्टरी तो एबनॉर्मलिटी नहीं है. नाउ दिस इज टेम्पोरल आर्टराइटिस, सो you would get a temporal artery abnormality. Okay, so how would you know that there is temporal artery abnormality? You will palpate this, so there would be tenderness on palpation. Okay, so patient will wince as soon as you touch, and then there would be reduced pulsations. So that's how you would know that there is a temporal artery abnormality. Okay, then fourth, there is a lab criteria. ESR would be raised. How much raised? More than 50 mm per hour. It would be raised, okay, by Westergreen method. And then you would do artery biopsy. Temporal artery biopsy is the gold standard method to diagnose temporal arteritis. So you would get a abnormal artery biopsy. Now what you will get in the biopsy? So that, as you know, that is an inflammatory vasculopathy, so you would obviously get an inflammatory infiltrate, but predominantly you will get a mononuclear cell infiltrate. Right, mononuclear cell infiltrate. Now this is also known as granulomatous arteritis, giant cell arteritis. So in this you would get granulomatous inflammation containing multinucleated giant cell. Right, so granulomatous inflammation containing multinucleated giant cell. Now let's just revise the ACR criteria. Very important criteria. ACR criteria is American College of Rheumatology criteria. So you need more than equal to 3 criteria out of the 5 criteria. So firstly, as we discussed, first two are history, third is your examination, fourth and fifth are your investigation. Now firstly, the age at disease onset would be more than equal to 50 years. There would be new onset headache in the patient or new type of localized pain in the head. Now there would be temporal artery abnormality, that is tenderness on palpation and reduced pulsation. There would be raised ESR, that would be more than equal to 50 mm per hour, and there would be abnormal artery biopsy. In abnormal artery biopsy, you would get predominant mononuclear cell infiltrate and granulomatous inflammation containing multinucleated giant cells. Okay, so this is your ACR criteria. It has a sensitivity of 93.5%, 93.5%, and it has a specificity of 91.2%. Okay, so here there is your ACR criteria. Now let's move on to the history of giant cell arteritis. Okay, so onset of giant cell arteritis, it could be abrupt or it could be insidious. Okay, so firstly patient would present with prodromal features or constitutional symptoms would be there. What are the constitutional symptoms? Fever, malaise, myalgia, your night sweats, weight loss. So fever, malaise, myalgia, night sweats, and weight loss. These are your constitutional symptoms. Now this is prodrome. It could last from It could come within few days and it could last for weeks. So these were your constitutional symptoms. Now let's move on to the symptoms, other symptoms. So now there are your common symptoms, and there are your less common symptoms. Now for example, this is the patient, this is the tongue. Okay, so firstly the patient will have a headache. As we discussed in the ACR criteria, there is new onset headache, new type of headache, and this headache would be restricted in the occipital or temporal location. Now patient could experience amaurosis fugax, so something called as amaurosis fugax. What is amaurosis fugax? It is transient monoocular loss of vision, which usually occurs in this patient due to anterior ischemic optic neuropathy. Now patient could get facial pain on chewing. Why would the patient have pain? Because of ischemia of maxillary artery, which supplies the masseter muscle. Now the patient could have tongue infarction. Tongue infarction is the pathognomonic sign in giant cell arteritis. Now for example, and also as we discussed that it is associated with polymyalgia rheumatica. So what would happen? Neck, shoulder, trunk, or pelvic girdle. Patient can observe pain in neck, shoulder, trunk, pelvic girdle, etc. due to polymyalgia rheumatica. Okay, so these are your common symptoms experienced by the patient. Now there are certain less common symptoms also, like patient, there could be scalp necrosis, which is rare. There could be affective or psychotic symptoms. Affective or psychotic symptoms. Now patient could experience diplopia or ptosis. Diplopia and ptosis would happen in 2% of the patient, or the patient could have scintillating scotoma. Scintillating scotoma in 5% of the patient. Now patient can observe facial pain. Facial pain is rare, but it could happen. Scalp necrosis, affective psychotic symptoms, they are also rare, but it could happen. Now patient could experience tongue or throat claudication, right? Tongue or throat claudication occurs in around 4% of the patient. Patient could experience tongue numbness, which could happen in 2% of the patient, and even necrosis, which is rare. Okay. Also, what would happen? Patient could experience carpal tunnel syndrome or peripheral neuropathies, which can occur in 5% of the patient, right? And also there could be certain myelopathic symptoms which could occur in 1% of the patients. Now let's see this in detail. Headache. Firstly, the patient can observe headache. Headache could be temporal or occipital, and as there is in the ACR criteria, it could be new onset headache or new onset of localized pain, occipital headache. Okay. Now facial pain on chewing. Now why would the patient experience facial pain on chewing? To chew, which muscle we use? We use your masseter muscle, right? Masseter muscle we are using, and the supply to masseter muscle is maxillary artery. So there would be ischemia in maxillary artery, right? So there would be ischemia in maxillary artery, which supplies the masseter muscle. So patient can experience facial pain on chewing. Okay. Now tongue infarction, as we discussed, which is pathognomonic. Then patient could have neck, shoulder, trunk, pelvic girdle pain due to polymyalgia rheumatica. This is important. Polymyalgia rheumatica in giant cell arteritis. Now amaurosis fugax. There is something called amaurosis fugax, which you would have learned in ophthalmology. What is this? It is transient Monoocular loss of vision. It occurs in 10% overall cases in giant cell arteritis, and 8% of cases experience some degree of permanent visual loss. Okay. Now why this is occurring? The commonest cause is anterior ischemic optic neuropathy, right? So optic nerve is supplied by posterior ciliary arteries, and then there would be ischemia of posterior ciliary arteries, ischemia, which would lead to anterior ischemic optic neuropathy. So these are your clinical features. Till now we have discussed what all we have discussed. We have discussed the names of giant cell arteritis, epidemiology, etiology, pathogenesis, ACR criteria, clinical features, then history, certain findings, and then we would see presentation. Presentation of giant cell arteritis. So approximately half of the patients would come with superficial temporal artery inflammation. Right? So superficial temporal artery inflammation, as the name suggests, temporal arteritis, so there would be inflammation of temporal arteries. Now what are the signs of temporal artery inflammation? Inflammation signs, so there would be erythema, there would be pain on palpation, patient would experience tenderness, you can see erythema, pain on palpation, then there would be nodularity when you palpate, then there can be thickening of the artery, temporal artery, and there could be reduced pulsations on the affected site. Okay, so what could have happened? Erythema could occur, pain on palpation, tenderness, as we discussed in ACR criteria, there would be tenderness and there would be reduced pulsation. Also there could be nodularity and thickening of the temporal artery which could occur. Now you can also hear carotid bruit. In about 10 to 20% of the patients you can hear a carotid bruit. So now vision loss could occur in patients, right? So vision loss mostly precedes fundoscopic changes, precedes by 36 hours. Usually it precedes by fundoscopic changes of infarction of optic nerve by 36 hours. So this is a very important complication of giant cell arteritis, vision loss, blindness. Now you can do ophthalmoscopy. What can you see on ophthalmoscopy? Now in acute anterior ischemic optic neuropathy, there will be sludging of blood in retinal arteries. Okay, sludging of blood in retinal arteries. Then there would be chalky white pallor or edema on optic disc, as there is anterior ischemic optic neuropathy. There would be chalky white pallor. Why would it be? Because there is ischemia of posterior ciliary arteries. So chalky white pallor or edema on optic disc. Now you could get this with or without splinter hemorrhage along the disc margin. With or without splinter hemorrhages. Along the disc margin. Okay, so in ophthalmoscopy you would be getting sludging of blood in the retinal arteries, chalky white pallor or edema on the optic disc, with or without splinter hemorrhages on the disc margin. Please save the record. Okay, so there would be as we discussed till now, presentation. Now what would be the presentation? So approximately half of the patient would have superficial temporal artery inflammation. Now what are the signs of temporal artery inflammation? The patient would experience erythema, pain on palpation, nodularity, thickening, reduced pulsation on the affected site. Carotid bruit would be present in 10 to 20% of the patient. Now, vision loss would proceed by 36 hours. The fundoscopic changes of optic nerve infarction. On ophthalmoscopy, due to AION, you can see sludging of blood in retinal arteries, chalky white pallor or edema on optic disc with or without splinter hemorrhages along the disc margins. So, you would do certain lab investigations. Now, what are the lab investigation you would do? So, there you should know that there is no specific diagnostic biomarker for giant cell arteritis. Okay, no specific diagnostic biomarker. So, what you would do? Lab investigation, you will get evidence of systemic inflammation. Evidence of systemic inflammation you would get. So, what will you do? You would do CBC of the patient, routine test. You would do ESR of the patient, CRP of the patient. These are all the routine tests which you do. Okay? LFT, KFT you can do. So what you will get in CBC? Anemia. Anemia you would get, which would be normocytic, normochromic anemia. Okay? Due to systemic inflammation. And then there would be thrombocytosis. Thrombocytosis में usually more than 4 lakh platelets if there, then there is increased likelihood of giant cell arteritis if there is more than 4 lakh platelets. Now ESR would be raised as we discussed in ACR criteria. Raised ESR is the hallmark, usually more than 50. Then LFT, CRP is also, you can get raised CRP due to systemic inflammation. LFT you would get raised alkaline phosphatase, raised transaminases. Okay? Due to ongoing systemic inflammation, you would get raised transaminases. Now, as we know that there is vasculopathy, so there is mural inflammation or luminal changes in the extracranial arteries. So we could do a PET scan with 18 FDG. What is FDG? Fluorodeoxyglucose. Then MRI, or we can do a CT. What will it detect? It will detect mural inflammation or luminal changes in extracranial arteries. Okay, mural inflammation or luminal changes in extracranial arteries, it would detect. You could also do a color duplex. Color duplex USG you could do. What will you get? You will get a hypoechoic halo around the temporal artery lumen. So hypoechoic halo around the temporal artery lumen. So this all you can do. Now the gold standard for the diagnosis is your superficial temporal artery biopsy. Yes, superficial temporal artery biopsy. This, my friends, this is the gold standard for the diagnosis. Okay, so as we discussed, what is the histopathological center? It is the tunica media and tunica intima. So what you will get in the intima? You will get intimal proliferation. Due to intimal proliferation, what you will get? There could be luminal stenosis and there could be intravascular thrombosis. Yes, in the intima, there could be intimal proliferation due to all the growth factors, interleukins, proteolytic enzymes. There could be luminal stenosis, there could be intravascular thrombosis. Now, in media, you would get invasion or necrosis of media. So, it can usually involve whole of the artery leading to panarteritis you can get. Now let's talk about the inflammatory infiltrate. As we already discussed the inflammatory infiltrate, it is predominantly mononuclear cells. You could get granulomatous inflammation along with giant cell formation, multinucleated giant cell formation. Granulomatous inflammation with giant cell formation. Okay, so for the management part, so this is very important in giant cell arteritis, that the patient has a complication of going blind, right, blindness. So it is always recommended that there is immediate administration of high dose corticosteroid therapy. Okay, so you don't have to wait for the confirmation of diagnosis. As soon as you suspect as soon as you suspect the diagnosis, so you would start the therapy. So there is immediate administration of high dose corticosteroid therapy, that is ASAP, as soon as you suspect the diagnosis, as you know, because there is impending nature of blindness in this patient. So due to impending nature of blindness, okay, so you would have to immediately administer. So now how much you would administer? So if you suspect giant cell arteritis, okay, so in a suspected case, you would start the patient on steroids, that is oral prednisolone. Oral prednisolone, usually how much you would give? 40 to 60 mg per day. Okay, followed by you would do a temporal artery biopsy within 1 week, as it is the gold standard. So temporal artery biopsy within 1 week, but you have to immediately start the patient on oral prednisolone 4 to 60 mg per day. Now if the patient have certain visual symptoms or certain neurological symptoms you notice, okay, then how much you would give? You would give 80 to 100 mg per day of oral prednisolone, right? Here you would give him 40 to 60, but if you suspect that the patient has visual or neurologic symptoms, you would give him 80 to 100 mg per day of oral prednisolone. Okay. Now, if the patient has acute visual changes, you would straight away start him on IV methylprednisolone pulse therapy. Okay. So IV methylprednisolone, what is this? Pulse therapy, 500 to 1000 mg per day for 3 days. Okay, you would start the patient, and then after 3 days you would give him oral prednisolone, and then steroids, you have to taper the steroids. So you would taper slowly over 2 years. Okay, so what did you see till now? That if you suspect a case of giant cell arteritis, you have to immediately start corticosteroids. So if you suspect, you will initially start the patient on oral prednisolone at 40 to 60 mg per day, and you would do a temporal artery biopsy within 1 week. If the patient has some visual or neurologic symptoms, then you would start the patient on 80 to 100 mg per day of oral prednisolone, which is approximately double of the dose. Then if the patient has acute visual changes, then you have to give the patient IV methylprednisolone pulse therapy, which is 500 to 1000 mg per day for 3 days. Then you have to switch the patient on oral steroids, which is oral prednisolone, and then you have to taper slowly for 2 years. Now this is all about steroids. There is one interleukin 6 receptor antagonist, okay, which is tocilizumab. Tocilizumab was approved by the US FDA in May 2017. Okay. So what will tocilizumab do? It has observed that tocilizumab would lead to one faster remission and prolonged maintenance of remission. Okay. Faster remission and prolonged maintenance of remission. And also it significantly reduces the corticosteroid doses. There is significant reduction in corticosteroid doses. Now, if there are certain steroid sparing agent, now if the patient who required prolonged treatment with steroids, especially high dose corticosteroids, if the patient is requiring like more than 5 to 10 mg per day, okay, or if the patient develops significant steroid related complications, then you could start the patient on steroid sparing agents. Now steroid sparing agents, which are cyclosporin, azathioprine, methotrexate. These are certain steroid sparing agents which would give the patient. So this is all about giant cell arteritis, guys. Okay, so in this section we discussed giant cell arteritis in detail. So firstly, we saw giant cell arteritis, the other names of giant cell arteritis, the epidemiology, etiology, pathogenesis of giant cell arteritis, its clinical features. Here is the ACR criteria, the history, then presentation, investigations, and management. Okay, thank you.